Hello everyone, welcome to Easy Medicine. Today we are going to discuss this topic, pulmonary embolism. So we are going to understand this topic in this brief outline, starting with the etiology, pathophysiology, clinical features, evaluation, and management. Now let's start with the etiology. Before we delve into the causes of pulmonary embolism, look at the virtuous triad. The virtuous triad is a triad of endothelial dysfunction, venous stasis, and hypercoagulability. Let's look at the causes under each heading. So the causes of endothelial dysfunction could be hypertension, bacteria, and artificial valves. See, the artificial valves will create a turbulent flow downstream and that will result in endothelial damage. Even hypertension will also cause shear stress on the arterial wall and that will also result in endothelial damage. Of course, the bacterial invasion, as in case of infective endocarditis, we have seen there is endothelial damage. Then comes the venous stasis. The venous stasis can be seen in bedridden patients, those who are doing a long haul travel, and obesity. The causes of hypercoagulability are pregnancy, oral contraceptive pills, hormone replacement therapy, carcinoma, COPD, CKD, and the prothrombotic states like factor V Leiden mutation, prothrombin gene mutation, deficiency of protein C, protein S, and antithrombin. The COPD is also a hypercoagulable state. Why? Because of chronic hypoxemia, there is upregulation of hypoxia inducible factor, which will further upregulate endothelin 1, which will predispose the patient to develop thrombosis. Chronic kidney disease, because of the uremic toxins, they can also induce hypercoagulability. Now let's look at the pathophysiology. The problem mainly there at the pulmonary artery now. So here there is pulmonary embolism. There are effects backward as well as forward. There is pulling up of blood because of the obstruction and the right ventricle has to pump with a significant amount of pressure. So the closure of pulmonary valve is delayed. So there is a late P2 and there is a split S2. And since the right ventricle has to pump against significant amount of resistance, there is right ventricular strain. And that will result in right ventricular ischemia. Sometimes microinfarcts in the right ventricle can result in right ventricular MI as well. So further, the blood is not able to enter into the pulmonary aorta and hence it regurgitates back into the right atrium. So that will result in tricuspid regurgitation. And further, the right atrial pressure is increased, which is clearly visible in the form of elevated JVP when you look at the neck veins. Now let's look at the forward flow. So since there is obstruction to the forward flow of blood from right ventricle into the pulmonary aorta, the lungs will get very little amount of blood. So the perfusion is reduced, but the ventilation is okay. So there is VQ mismatch. And whenever the alveoli are getting less amount of blood flow to the alveoli, what will happen? The pulmonary vasoconstriction happen. This is a reflex or a compensatory mechanism. This is done to shunt the blood from the abnormal alveoli to the normal alveoli where the circulation is supposed to be normal. Okay, but when there is this pulmonary vasoconstriction and the VQ mismatch, there is hypoxemia, and this hypoxemia will stimulate the respiratory centers in the brainstem, and the work of breathing is increased, and the patient will have dyspnea. Now, further, the preload to the left ventricle is reduced. That is the reason for reduction in the stroke volume. The cardiac output is reduced, systolic blood pressure is reduced, and eventually the patient may land up in shock. Whether the patient lands up in shock or not depends upon the severity or size of the pulmonary embolus. Now, if there is a deep venous thrombosis, the most common presentation would be cough, pain, and tenderness. Of course, the patient will also have pedal edema because the blood is not ascending upwards through the deep veins. And pulmonary embolism. The pulmonary embolism is called as a great masquerader because the presentation can be quite asymptomatic to sudden death as well. How will it vary? Let's understand. Now, here is a normal lung. What you can observe here is the right ventricle, and originating from it is the pulmonary aorta, which is further dividing into right main and left main pulmonary arteries. And you can see the further branching of the pulmonary arteries as well in the lungs. In the first image, the right pulmonary artery or the right main pulmonary artery is blocked. So there is a large embolus blocking the right pulmonary artery, and the entire blood flow to the right lung is gone. Okay, so that will result in massive pulmonary embolism. I'll explain you the clinical features in the next subsequent slides. How will it present? Now let's look at the second image. So here the embolus is in the distal branch pulmonary artery. What will happen? The part of the lung which is supplied by this distal branch undergoes infarction. And when there is a pleura overlying it, there is pleural irritation as well, and the patient can have pleuritic chest pain. This will result in submassive pulmonary embolism. Now look at the third image. In the first and second image, the emboli are acute or sudden, whereas in the third image, the formation of thrombus is quite gradual and the thrombus is organized and there is fibrosis in the vessel because of vascular remodeling. What will this happen? Because of gradual obstruction of the pulmonary artery, there is also development of collaterals, as you can appreciate in the image. So because of these collaterals, the perfusion is more or less maintained, but the pulmonary vascular resistance is significantly elevated. So the chronic changes of the heart, that is the right ventricular strain, right ventricular hypertrophy, and all these changes of right heart failure will eventually keep on developing in this patient. Now let's see the presentation of these three types of pulmonary embolism. So there is a large embolus in the main pulmonary artery. The pulmonary vascular resistance is increased because of it, and the right ventricular afterload or the resistance against which the right ventricle has to pump the blood is increased. So there is acute right ventricular strain, and further because of the strain there is right ventricular ischemia or infarction, and eventually the patient will have a central crushing chest pain. Now, in submassive PE, there is a small embolus in the distal pulmonary artery, and that will result in localized infarction, and it can also result in irritation of the nearby pleura, and the patient can have a pleuritic chest pain. And in chronic pulmonary embolism, there is gradual and organized thrombus in the main pulmonary artery or its branches, and that will eventually cause increased pulmonary vascular resistance and increased RV strain and decreased LV preload. So because of this increased pulmonary vascular resistance, there is increased right ventricular strain, and since it is obstructing the forward flow, the left ventricular preload is also reduced. So the patient will have dyspnea because of increased work of breathing, like I already explained. So the clinical features are the chest pain, which is very severe and central crushing type of chest pain is seen in acute massive pulmonary embolism, and the patient will also have severe dyspnea because the entire lung is almost cut off, and the patient will also have syncope because the blood will not flow forward into the left side. And on examination, you will find hypotension, tachycardia, of course, as a compensatory mechanism, elevated JVP because of acute right ventricular failure, and loud P2 and cyanosis. And the ECG finding that we commonly see is an S1Q3T3 pattern. The treatment would be thrombolysis and anticoagulation. We'll discuss about the treatment in detail when we come to the treatment part. This is just a glimpse. So when we look at this S1Q3T3 pattern, it is not very sensitive and it is also moderately specific. If you want to remember one line about S1Q3T3, then it is the presence of S1Q3T3 makes the likelihood of PE high, but the absence of S1Q3T3 does not rule out pulmonary embolism. Okay. Now let's look at the presentation of submassive pulmonary embolism. The clinical features are pleuritic chest pain, dyspnea, and hemoptysis. On examination, you will see tachycardia, pleural rub, that is because of pleural irritation, crackles because of the infarction, and pleural effusion when it is overlying the pleura, and when there is pleuritis, eventually there is development of pleural effusion as well. On ECG, you will find sinus tachycardia, and the treatment is anticoagulation alone. And in chronic pulmonary embolism, there is no sudden obstruction to the pulmonary flow. There is gradual obstruction. That is why the patient will not have chest pain, but the patient will have exertional dyspnea and pedal edema because of right heart failure. On examination, you will see right ventricular hypertrophy or in the form of right ventricular heave and loud P2 and the features of right heart failure. ECG will show ST T wave changes in leads V1, V2, and V3. That is nothing but right ventricular strain pattern, and the treatment is anticoagulation. Now let's look at the evaluation. For evaluation of the pulmonary embolism, firstly we need to calculate the Wells score. There is a separate Wells score for DVT as well as pulmonary embolism. There are multiple points and we have to take these points into account for calculating the Wells score. So if you are suspecting DVT, see whether the Wells score is more than 1. If it is more than 1, do a leg venous ultrasound. If the leg venous ultrasound shows the presence of DVT, then the diagnosis is confirmed. But if the Wells score is not more than 1, but if you are still suspecting DVT, then do D-dimer levels. If the D-dimer is more than 500, then again do a leg venous ultrasound, which may show DVT presence. But if the D-dimer is not more than 500, then rule out DVT. After you did leg venous ultrasound, if the DVT is not there, but still if you are suspecting DVT, then do MR venography or rule out if you are not suspecting DVT. Now about pulmonary embolism. The evaluation of pulmonary embolism depends upon the hemodynamic stability of the patient, because you cannot keep on doing investigations if the patient is in shock, right? So let's see when the patient is hemodynamically stable. If you are suspecting pulmonary embolism, calculate Wells score. If the Wells score is more than 4, do CT pulmonary angiography. If the CT pulmonary angiography shows PE, then well and good, treat the patient. If the well score is not more than 4, then do D-dimer. If the D-dimer is more than 500, then it means the pulmonary embolism is possible. So do CTPA and rule out pulmonary embolism. If the D-dimer is less than 500, then the D-dimer is ruled out. If you are not able to find pulmonary embolism, but still if you are having a suspicion, then do VQ scan or invasive pulmonary angiography or rule out pulmonary embolism. That is in a case of hemodynamically stable patient. If the patient is hemodynamically unstable and if you suspect PE, don't try to calculate well score. It takes a lot of time. Directly do a transthoracic echocardiography. Look for right ventricular dysfunction. If there is RV dysfunction, then go ahead with CTPA and identify pulmonary embolism. If TTE is not showing any RV dysfunction, then search for any other cause. After you did CTPA, if the pulmonary embolism is not there, but still if you are suspecting, then you can go ahead towards VQ scan, invasive pulmonary angiography, or rule out if you don't have any suspicion. Now let's look at the radiological investigations. If you see a chest X-ray, it is more likely normal. And sometimes you can see pleural effusion and certain other signs. What are these signs? The circled in the first image, you can appreciate a small opacity which is nothing but lung infarction. It is called as the Hampton's hump. In the second image, you can see an area of lung which is not having any significant vascular markings. This is because of focal oligemia. So when there is a significant thrombosis of the pulmonary artery, what will happen? The part of lung which is supplied by the pulmonary artery will not get the blood flow. That will appear in the form of focal oligemia on a chest X-ray. That is called as the Westermarck's sign. Now look at the bottom circle where you can see the prominent right pulmonary artery. So whenever there is a distal blockade, the proximal pulmonary artery is ballooned out or dilated. Okay, that is visible in the form of large right pulmonary artery and that is called as the Pallas sign. So the investigation of choice would be CT pulmonary angiography, but the gold standard is invasive pulmonary angiography. The invasive pulmonary angiography means you will introduce a catheter through the peripheral vein till the pulmonary artery and then you inject the contrast. This is quite invasive and hence it is not the preferred investigation. The investigation of choice would be CT pulmonary angiography, but if you are not able to identify in CT pulmonary angiography, then the gold standard would be invasive pulmonary angiography. And the ventilation perfusion scan. Like we already discussed, there is normal ventilation but the perfusion is reduced. That is visible in VQ scan if you want to do it. When you look at the blood investigations, NT-proBNP is increased because there is right ventricular strain, BNP is produced from the ventricle, so there can be an elevation in NT-proBNP. And even because of right ventricular microinfarcts, troponins can also be elevated. And when you look at a 2D echo, you will find right ventricular free wall which is hypokinetic with the preserved RV apical contractility. This is called as the McConnell sign. What is McConnell sign? Right ventricular free wall hypokinetic but with the preserved RV apical contractility. Now let's look at the treatment. If the patient is having a massive pulmonary embolism, straightly go ahead with thrombolysis with alteplase 100 milligrams IV infusion over 2 hours. Then if the patient is in shock, you can give 1 pint of NS, but further fluids are cautiously given. And avoid diuretics because it will further reduce the preload. And the first line vasopressor and inotropes are the noradrenaline plus dobutamine. Noradrenaline is the first line vasopressor and dobutamine is the first line inotropic for this patient. And further, after the thrombolysis, you should continue anticoagulation. Now, how would you treat a submassive PE and a low risk PE? There is no need for thrombolysis here. There is only role for anticoagulation in this patient. But how would you give anticoagulation? So there are 3 anticoagulation strategies for the management of the pulmonary embolism patient. So start with unfractionated heparin or low molecular weight heparin or fondaparinux, which is associated with a 5-day bridging with warfarin followed by warfarin alone. This bridging reduces the initial procoagulant activity of warfarin. As you can see, so for the first 5 days, on day 1, start with heparin as well as warfarin. Continue both of them for 5 days. This is called as the 5-day bridging. Followed by, you can use warfarin alone indefinitely. But what is this initial procoagulant activity? Warfarin will block all the vitamin K dependent factors. So we know that it is going to block the vitamin K dependent factors like 2, 7, 9 and 10. But in the initial 5 days, it is also going to block the anticoagulants like protein C and protein S. So during this 5-day period or till the INR reaches our therapeutic range, you should continue another anticoagulant, which is heparin. Now, the other way is to start with the low molecular weight heparin or fondaparinux for 5 days, followed by the next day shift to novel oral anticoagulant agents. There is no need for bridging here. And the third strategy is to start with the novel oral anticoagulant with 1 week loading dose followed by maintenance. These are the three strategies of anticoagulation in a patient of pulmonary embolism. Now, there is a pharmacomechanical strategy as well, where you can give alteplase 25 mg IV infusion followed by catheter-based thrombectomy. Then you have surgical modalities also available, which is a pulmonary thromboendarterectomy, usually suggested in chronic thromboembolic pulmonary hypertension. And this can be potentially curable for a case of CTEPH, that is chronic pulmonary embolism. And for monitoring of the anticoagulation, if you are giving unfractionated heparin, monitor APTT and the target should be 60 to 80 seconds. If you are giving warfarin, the target INR should be 2 to 3. And for low molecular weight heparin or the novel oral anticoagulant agents, there is no requirement for monitoring. Now let's look at the prevention. So if the patient is having any kinds of venous stasis or hypercoagulability or the risk of endothelial dysfunction, if you think that the patient is at high risk for development of DVT, then you should go with the primary prevention. For primary prevention, you can use pneumatic compression stockings. But if the patient already has a previous history of DVT or pulmonary embolism, if you want to prevent further episodes of DVT or PE, then what you are doing is secondary prevention. So for secondary prevention, you'll use drugs like low molecular weight heparin or novel oral anticoagulant agents. If the bleeding risk is high, then you can place IVC filters. So here is an IVC filter that is shown in the image. If the thrombus is not dissolving even with intense anticoagulation, then also you can prevent its embolization from deep venous thrombosis to the pulmonary circulation by placing an IVC filter. So this is all about pulmonary embolism. Hope you find value in this video. If you like this, please share this to your friends and subscribe to my channel. Thank you. And of course, follow the free notes on my Easy Medicine app.